FEP number. And our chairman and founder is Dr. Dhara Shah, who has innovated multiple innovative technologies. He has written a book on pelvic floor and a lot more in the field of pelvic floor. So in this today's webinar, we will be discussing a lot about a specific condition which is known as vaginismus. But before we understand what is vaginismus, it is very important for us to know that what do we mean by pelvic floor muscles. So what are the pelvic floor muscles and why do they go for dysfunction? So this is my favorite model. You will always find me in the webinars with this model. So let me explain you what pelvic floor muscles are. Many of you already know what these muscles are. For some, it might be a new word. So you all can, pin my video on your screen so that the pelvic floor model would be highlighted, and the host can even spotlight my video for everyone so that they can see the pelvic floor. Okay, so yeah, you can see here, this is the symphysis pubis, right? This is a female pelvis, this being the symphysis pubis. This is ASIS on the right side, ASIS on the left side. If I give you an inferior view, then this is the ischial tuberosity on the right, the ischial tuberosity on the left, and posteriorly, you can see the spine and the coccyx. So basically, a group of muscle which is connecting these four bony prominences. Which four bony prominences? Symphysis pubis, ischial tuberosities, and coccyx and the sacrum. So this diamond-shaped muscle is the pelvic floor muscle. Okay, and the pelvic floor muscle, it is very simple. The muscle which is connecting your symphysis pubis, ischial tuberosities, and coccygeus is the pelvic floor muscle. And it is not a single muscle. It has multiple layers to it, and it has different muscle fibers in it. So which are the muscles in the pelvic floor? We will quickly review the names of these muscles. We will not be going in details of every muscle. We will quickly see what are the names of this muscle. Why? Because when we are dealing with vaginismus or when we are dealing with any pelvic floor dysfunction, it is very important to differentiate that which muscle fiber is involved, how it is involved, and to what extent it is involved. Okay, so if we are talking about vaginismus, if we are talking about dyspareunia, so to understand the difference between both, to understand the basic pathology, we should know what are the layers of the pelvic floor muscles. So the pelvic floor muscles, they basically have three layers. Superficial layer, the layer which you can see right now. So you imagine a person in supine position with hip and knee flexed and abducted, and you are seeing the perineal area. So the first thing which you happen to see would be the skin, the hair follicles, the skin. If you will retract the skin, there would be the subcutaneous fascia and the fat. If you retract that, you will first get the first layer of the pelvic floor. And the first layer of the pelvic floor has four muscle fibers into it. The first layer has four muscle fibers into it. These are the bulbocavernosus. Okay. Sorry, these are the bulbocavernosus, the ischiocavernosus, the superficial transverse perineal, and the external anal sphincter. I'm repeating once again. The four layers of the pelvic floor on the superficial layer, the four muscles of the superficial layer are the bulbocavernosus, the first one, the ischiocavernosus, the second one, the superficial transverse perineal, the third one, and the external anal sphincter, the fourth one. Okay, very easy. You can remember as IBS-A, IBS, inflammatory bowel syndrome, IBS-A. Okay, so I for ischiocavernosus, B for bulbocavernosus, S for superficial transverse perineal, and A for external anal sphincter. And you can easily see that these muscles are very slender muscles or very thin muscles. They are not very much developed, or they are not striated one. They are the singulated muscle fibers. Okay. And they have more of a opening layer, more of a power output. So these pelvic floor muscles, the superficial layer, has more of the fast twitch muscle fibers, and they specifically work for a power or quick contractions, sudden contractions. Okay. So these muscles, which we just saw from the perineal body, you can see here, this is the perineal body. From the perineal body, a muscle running towards the ischial tuberosity is the superficial transverse perineal muscle, the muscle which runs through the ischiopubic ramus. Okay, through the ischiopubic ramus is the ischiocavernosus muscle, right? So ischiocavernosus. Okay, then the muscle. Oh, you cannot. Okay, there is something in the chat box that they cannot hear me. Am I audible to others, or I am
You're
not
clearly audible? I'm extremely sorry I've joined late, Dr. Dhara.
That's fine.
You're clearly audible, at least to me. I think the others can also convey if it's audible to them.
Okay,
Yes.
I think then there would be, yeah.
For those who are not able to hear Dr. Dhara, please can you try to join in again?
Yes, or you can just dial in through the call tune.
Yeah. Perfect. I think it's audible to all. I think we can continue.
Great.
All right.
Great. Thank you. Thank you. Yeah. So when we are talking about these muscles, I was explaining you about the superficial transverse perineal muscle, the bulbocavernosus muscle, and the ischiocavernosus. Okay, so these muscles, they are the small muscles having more control on the power output. So they are the they are the muscles which will be activated when you need a fast twitch muscle activity. Does not mean that they will not work when you are contracting the muscle for endurance. See, a very beautiful pelvic floor muscle behavior is it can function isolatedly by its own. I mean, if you want to urinate, you are just using your external urethral sphincter. If you want to defecate, you are using your puborectalis and external anal sphincter. If you want to have a vaginal penetration, you are working upon your bulbocavernosus and pubovaginalis muscle. Okay, but when you voluntarily contract your pelvic floor, okay, when you voluntarily or willingly contract your pelvic floor, you are contracting the muscle as a whole. Okay, you are contracting the muscle as a whole, but the muscle involuntarily or physiologically can isolatedly work. Okay, but whenever, like when I'm saying that bulbocavernosus and ischiocavernosus or the superficial layers, they have more of fast twitch contractions. Okay, means they will have fibers both slow twitch and fast twitch, but their predominant work will be quick contractions. Okay, so not going in too much detail of the muscle fibers, individual muscle fibers, just giving their one function. So the bulbocavernosus is responsible for opening and closing of the vaginal orifice. Okay, so whenever you see a bulbocavernosus, you palpate a bulbocavernosus near the vaginal orifice, you can see its movement, its flickering. Secondly, it will increase the blood supply towards the clitoris. So when your bulbocavernosus is contracting, it will increase the clitoral blood supply, which is responsible for sexual pleasure. Okay, so the females, specifically even the cases with vaginismus, you might find that the bulbocavernosus can be into spasm or can be tight. Okay, so that's why it's important to understand different layers of pelvic floor, because every layer has its own specification, every layer has its own role. Okay, so this was just an example of bulbocavernosus and vaginismus. Second can be the ischiocavernosus. So the ischiocavernosus muscle is responsible for maintaining the erection of the clitoris. So whatever erection the clitoris has got during the sexual activity, that would be maintained by the work of ischiocavernosus and bulbocavernosus by increasing its blood supply. The superficial transverse perineal muscle is responsible for the perineal body stability. You need to see, perineal body is the center point where all the muscles of superficial layer, the internal fascias, the perineal pouch, everything is attached. So you want to have a well-integrated perineal body. That has been done by the superficial transverse perineal muscle and the deep transverse perineal muscle, which we will be seeing next. Okay. And one more muscle present in the superficial layer is the external anal sphincter. And this external anal sphincter is responsible for fecal continence. So relaxing when you want to defecate and tightening or contracting, tightening is a wrong word, contracting when you want to maintain the continence. Okay, so the superficial layer of pelvic floor muscle consists of 4 muscles: bulbocavernosus, ischiocavernosus, superficial transverse perineal, and external anal sphincter.
Bulbocavernosus.
Okay. Yes, bulbocavernosus,
Super.
ischiocavernosus, superficial transverse perineal muscle, and external anal sphincter muscle. Okay. This was just an outline of the superficial layers. Then comes the middle layer. Now, when we talk about the middle layer is made up of by the deep transverse perineal layer. Okay, the deep transverse perineal layer. And the deep transverse perineal layer is responsible for making the external urethral sphincter fibers. So the fibers of the external urethral sphincters, some of them, they also originate from the deep transverse perineal layer, and they form the external urethral sphincter. Okay, and it also helps to stabilize the perineal body. And then comes the deepest layer of pelvic floor, that is the levator ani, the deepest layer of pelvic floor, that is the levator ani. So you can easily see the difference, like how the pelvic floor was superficially only small muscles, sphincteric muscles, longitudinal muscles, okay, but they were not spread all across, and how it gets changed or how it gets modified or well differentiated when you go to the deeper layer. This is the deepest layer, and we all know its name. What do we call the deepest layer of pelvic floor? The levator ani. Okay, so this is the levator ani, right? And the levator ani itself has multiple muscle fibers. Okay, the levator ani has multiple muscle fibers. Those muscle fibers are the pubococcygeus, the centralmost from the pubis till the coccyx. The pubococcygeus, okay, the iliococcygeus, and the coccygeus. So we have in the levator ani, it's made by the pubococcygeus, the iliococcygeus, and the coccygeus. And these are the muscles which are responsible for the endurance, the support. Okay, these are the more of the slow twitch muscle fiber. These are more of the slow twitch muscle fiber, which are responsible for supporting the organs, providing stability and the endurance work that has been done by this layer, the deepest layer of the pelvic floor. Okay, the pubococcygeus also gives rise to pubourethralis, which supports the urethra, pubovaginalis, which supports the vagina, and puborectalis. So need not worry about remembering the names of all muscles right now. Okay, just try to understand and visualize how beautiful the pelvic floor muscles are and how beautifully they are intervened with one another. Okay. So repeating the deepest layer once again, from the pubic symphysis till the coccyx, we have the pubococcygeus, the iliococcygeus, and the coccygeus. The pubococcygeus further has the pubourethralis, pubovaginalis, and puborectalis. Okay, which, as their name goes, they would support the urethra, the vagina, and the rectum. Okay, and here you can see this one. Which muscle fiber is this? Which muscle fiber is this? Can anyone guess the name? Which muscle fiber is this? Okay, it is obturator internus. Okay, it is obturator internus. And from the fascia of obturator internus, we have the origin of the iliococcygeus and the coccygeus. Okay, and that is why it is very much integral to examine the hip internal external rotation in cases of pelvic floor dysfunction and vice versa. If you have a hip pathology, you can have a pelvic floor involvement. And if you have a pelvic floor involvement, you can have a hip pathology. The connection is, and there are multiple reasons, the proximity, okay, the connectivity, and the supportive function. Okay, this is a direct, like, hip the obturator internus is in hip rotator, and its fascia is giving the attachment to the iliococcygeus and the coccygeus. So any dysfunction in this attachment or this area can result into either a pelvic or a hip pathology. Okay, so this was just a brief of pelvic floor muscles. Just let me quickly revise the muscles once again before we go ahead. Okay, so this is the bulbocavernosus, this is the ischiocavernosus, the superficial transverse perineal, the external anal sphincter, and the deep transverse perineal muscle, and then comes the levator ani. The levator ani, which is made up of pubococcygeus, iliococcygeus, coccygeus, and the obturator internus, giving fibers to, like, its fascia, giving origin to the iliococcygeus and the coccygeus. Now, this pelvic floor muscles, basically, what is the function of pelvic floor muscle? So the function of pelvic floor muscles are supportive. They will support the internal organs. So if this is the pelvic floor, okay, you can see this is the pelvic floor. So this pelvic floor will support the internal organs. It will support the urethra, it will support the vagina, the bladder, the rectum, the uterus, like this. So first is the supportive. Second is stabilization. It will work as a core stabilizer. It is one of the core muscles. Okay, the central core muscles. So it will work as a core stabilizer. Okay, so it will work as support. It will work as stabilization. It will have a sphincteric control. What do we mean by sphincteric control? Sphincteric control means the ability to maintain the continence as well as the ability to relax and urinate. Okay, so sphincter control means whenever I want to urinate, my muscles are able to relax, open, and let me urinate. And whenever I want to maintain the continence, my muscles are strong enough to support the urethra and maintain the continence. Okay, suppose this is the urethra. This is the urethra. So my pelvic floor muscles will be able to relax. Let me give a better example. Let's consider this as the urethra. Okay, so now my pelvic floor muscles, when I want to maintain the continence, they will be contracted, and they will maintain the closure. Okay, and when I want to urinate, they will relax and open. So there's both the contraction as well as the relaxation. This together is known as the sphincteric control. So support, stability, sphincteric activity, sexual activity. As we said, the bulbocavernosus, the ischiocavernosus muscles, they will pump the blood towards the clitoris to maintain the erection and ultimately to increase the intensity of orgasm. And the pubococcygeus muscle or the levator ani muscle will be responsible for the vaginal grip over the penis during sexual activity. And then comes the lymphatic role. Your diaphragm and your pelvic floor functions in coordination with each other to maintain your intra-abdominal pressure. So that is the lymphatic role of the pelvic floor. So out of these roles, other than that, also it has a postural role, it has its role in pregnancy and childbirth. Okay, so other than the roles or like other than the function, what can be the dysfunction? So the dysfunction of pelvic floor are quite easy. They are quite simple. Okay, so the dysfunction can be of three types. Those can be a hypotonus dysfunction, a hypertonus dysfunction, or a incoordinated dysfunction. Okay, a hypotonus, a hypertonus, or a incoordinated. So when we say a hypotonus, okay, that means the muscle will become so weak, so loose that it will open up. It will not be able to support the internal organs. It will not be able to maintain the continence. It will not be able to stabilize the core. It will not be able to give a grip during sexual activity. So it is becoming loose. It is becoming weak. It's not able to tighten up. So this is the pelvic floor. This is its strength and this is the relaxation. A hypotonus will be a muscle which is not able to contract fully and completely. It will be loose. So if it is loose or weak, it will lead to urinary incontinence. It will lead to pelvic organ prolapse. It can lead to sexual dysfunctions. It can lead to fecal incontinence. There can be n number of lists of dysfunctions which can happen due to a weak pelvic floor. Okay, so that is a weak pelvic floor or a hypotonus. So in pelvic floor field, when we talk about tonus, that means the muscle tone. We are not maintaining the brain control or the higher motor control. So hypotonus does not mean flaccidity. Hypotonus means weak pelvic floor. Okay, and hypertonus, when we talk about hypertonus, hyper, H-Y-P-E-R, hypertonus, that means extremely tight or spasmodic pelvic floor. The muscles do not understand how to relax, when to relax, and how much to relax. So they end up into tightening, they end up into spasm, they end up into locking everything up. So that is a hypertonus pelvic floor. That is a tight or a spasmodic pelvic floor. And the third category is incoordinated. Okay. First one was the muscle does not know how to contract, when to contract, and how much to contract. That was hypotonus. Second was the muscle does not know how to relax, when to relax, and how much to relax. That is hypertonus pelvic floor. And the third is incoordinated. The muscle does not know how to contract, when to contract, how to contract. Also, it does not know how to relax, when to relax, and how much to relax. That is incoordination, lack of coordination of the pelvic floor. Again, it is not a neurological thing we are discussing. We are purely discussing the musculoskeletal part of pelvic floor. Okay, so now in the hypertonus category, there are two very much disabling terms which we should not overlook as a pelvic floor rehab specialist, and those are vaginismus, number one, and dyspareunia, number two. So vaginismus and dyspareunia, these are the two terminologies which are linked with hypertonus pelvic floor muscles. So when we talk about vaginismus, that means a condition in which a female is unable to insert anything inside the vagina. And please make sure it is sexual or even a non-sexual penetration. Vaginismus does not necessarily mean only a sexual penetration dysfunction. Vaginismus means and sudden unwanted contraction of the pelvic floor or spasm of the pelvic floor muscles, specifically over the vaginal orifice when a penetration is attempted. Okay, so this is the vaginal orifice. You can say this is the vagina. Okay, this is the vagina. So anytime, any type of penetration, it can be a penile penetration. So if it is a penile penetration, it is a sexual penetration, or it can be an asexual or a non-sexual, like tampon. When I'm inserting a tampon, or I'm inserting a menstrual cup, or my doctor has given me a suppository to be inserted via the vaginal route, and I'm unable to do so. Why am I not able to do so? Because of pain, because of spasm, because of inability to relax the pelvic floor. That means it is vaginismus. Okay, vaginismus or vaginismus, as you want to pronounce it, vaginismus or vaginismus. Okay, so this pelvic floor muscles, the outer 1/3 of vaginal canal. So if this is the whole vaginal canal, you can see the whole vaginal canal. Okay, so the inner 2/3 is the skeletal muscles, the smooth muscles, and the outer 1/3 is only the skeletal muscle. So your pelvic floor is only like this. Rest inside everything is smooth muscle. Okay. So this spasm, the unwanted sudden spasm of the outer 1/3 of the vaginal canal or the vaginal muscles is known as the vaginismus. That is vaginismus. Okay, your muscles are not able to relax, open, or allow a sexual or an asexual penetration. Okay, so that is vaginismus. And the second terminology is dyspareunia. Dyspareunia. Vaginismus is different and dyspareunia is different. Dyspareunia means when a female experiences recurrent persistent pain during or after sexual penetration. Okay, what was vaginismus? Vaginismus means no penetration at all, sexual bhi nahi, asexual bhi nahi. Dyspareunia means whenever a female is trying to allow a penetration, okay, the penetration is possible, but it is associated with pain, discomfort, tightness, burning, incomplete relaxation. Okay, so in 3 words, if we want to remember, vaginismus equals to no vaginal penetration. Okay, that is vaginismus. Dyspareunia equals to painful vaginal penetration. So if the female, or you can say like there are some symptoms. So vaginismus means no vaginal penetration. Dyspareunia means painful vaginal penetration. Or it can be a discomforting vaginal penetration. That is dyspareunia. Okay. So, and that is either during or even after the sexual activity. So that is a dyspareunia. Fine. Now, when we talk about the types of vaginismus, okay, here comes the understanding of pelvic floor. When it comes to the type of pelvic vaginismus, it can be a primary vaginismus or a secondary vaginismus. What do we mean by primary vaginismus? So primary vaginismus means, as the name suggests, primary, right from the very beginning. So the female could never achieve a vaginal penetration. Okay, she could not insert a tampon. She could not insert. Okay, let me explain you with a case study. A 23-year-old female came for the vaginal examination since she was going to get married within 6 months. So she happened to visit a gynecologist just to make sure that things are all okay. And why did she got that thought? She get that thought of assessing her was because now when she when she got engaged, her sister-in-law, she introduced tampon and menstrual cup to her. By now, she had never used a tampon or a menstrual cup. And her sister-in-law, she informed her about what is a menstrual cup and what is a tampon. So she got a menstrual cup and she tried to insert the menstrual cup. Her sister-in-law could easily insert it, but she could not. So she tried once, she could not. She thought maybe out of fear, and she left it. Next time she again tried, but she could not, and then she left it. And then that made her curious. So she Googled. The best answer in today's world is Google. You don't know anything, Google out. Patients will also come after Googling all the things, searching all the things. They will just come and tell you, okay, write this on your prescription note, because the chemist will not give me medicine until I have a doctor's prescription. So he does not need you. He just needs your prescription pad. Okay, that was on a funnier side, but that's true. Nowadays, patients Google everything. If we are the patient, we will also Google everything. So she Googled that what if I cannot have menstrual cup getting inserted inside my vagina? What can it be? And it came out that it can be vaginismus. An inability to have a vaginal penetration can be vaginismus. And that's why she went to visit a gynecologist. Now, when she visited a gynecologist, before she told that, ma'am, I'm unable to insert the tampon or the cup. And the gynecologist said, okay, let us examine you. So she took her on the examination couch to do an sonography to make sure that the tube is patent. Okay, means the hymen, sometimes it can happen that the hymen can be very thick. I mean, literally, it can be very much thick hymen, and that is not being perforated, or it is micro perforated. So she can still have menstruation, but she cannot have a penetration because of a thick walled hymen. Okay. So the gynec had to rule out all the possibilities, or whether then it can be a vaginal stenosis. Congenitally, the vagina can be stenosed. Even that can be a possibility. Okay. So she took her on the couch, and the nurse who was assisting the gynec, she saw her perineum and she commented that, oh, you have such a small opening. How will you allow a penetration? But that's it. This one sentence. Oh, you have such a small opening. How will you allow the penetration? This triggered the thought in her mind that my vagina is not normal. My vaginal opening is very small and I cannot allow a penetration. If I have a penetration, I have pain. And with the same thought, when she tried her first activity with her partner, she could not allow the penetration. So then she was being referred to a sexologist. The sexologist examined her and he told her, yes, you have vaginismus, you need a pelvic floor specialist. And that's how she came to us. So now this is a case of a primary vaginismus. The reason can be fear, big time, or any underlying pathology like endometriosis. Okay, majority of the times, whenever you are seeing a case with vaginismus or dyspareunia, there can be a lot of, or at a larger amount of a psychological involvement or fear of penetration that is leading to a spasm of the pelvic floor. So that was a primary, means right from the very beginning, she could not allow a penetration to take place. That is primary. Second is secondary. Secondary means acquired, means the penetration was possible earlier, but after an episode or maybe after a childbirth, the healing or the suturing ended up into pain over the vagina, and that's why she could not have a penetration. Okay, so that can be a secondary vaginismus. So it can be primary vaginismus or secondary vaginismus due to pain, due to tightness, due to discomfort. Okay. So there are certain factors which can result to vaginismus. As I said, big time there is a emotional factor, and even there can be a physiological and anatomical factors. Like a very common cause can be a sexual abuse in past, an abusive history, a sexual abuse, can lead to the grudge, the revenge, the attitude of the feeling of taking a revenge, the feeling of grudge, the feeling of impurity, or the feeling of why me, and the whole world is bad. So all these things, or maybe the experience, the emotional, disturbing, painful experience associated with the episode, that can also. And sexual abuse need not necessarily always mean an abuse to an extent of penetration. It can be a touch, and just and simple unwanted touch can even lead to a brain reaction, irritation, and withdrawal from the activity. Okay, so it is a very much prominent thing in a history portion. A painful experience while penetration. So the first attempt itself is very much painful. A fear of pain, fear of getting pregnant. Yes, I am in my, like, there are females who have a fear of getting pregnant. They don't want pregnancy because they are planning their career, or they are about to give their exams and they don't want their exams to be spoiled. So the fear of getting pregnant, fear of vagina being small, as I said the case, or a very strict upbringing where discussing about the sexual activity is considered to be a unwanted thing, or maybe is given the last, or even no priority. Okay, so these can be the emotional aspects, or there can be a physiological and anatomical, like childbirth perineal trauma. So when a female is delivering, okay, like through a vaginal delivery, and if she happens to have the perineal tear, when they are sutured, they can result into pain, they can result into irritate, they can result into vaginismus. So many postnatal mothers can come with dyspareunia and vaginismus. So don't keep a notion that every postnatal mother should be taught Kegels. No. Every postnatal mother needs a detailed examination. Whether to advise Kegels or not to advise Kegels stands always second after examination. Okay. So your childbirth perineal trauma, whether you have laxity, or you have tightness, or I mean you have scar, and that scar is giving you pain, and that pain is giving you pelvic floor spasm. Okay, pelvic organ related disorders, it can be endometriosis, interstitial cystitis, inflammatory disease. All these things can lead to vaginal spasms. Vulvodynia, vaginitis, vestibulitis, vaginal dryness, or even side effects of medicines like cancer drugs, cancer surgeries, or cancer treatments. So post breast cancer treatment or post gynecological treatment, there can be multiple side effects, multiple medicinal side effects which can be present. Or it can be dyspareunia. So when we talk about dyspareunia, again, dyspareunia can be superficial dyspareunia or deep dyspareunia. Superficial or deep. It can also be primary or secondary. So primary or secondary means, as I explained, it can be like present from the very beginning, or it has happened due to an episode. Okay, and what do we mean by superficial dyspareunia and a deep dyspareunia? Let me explain it. So when we talk about the superficial or the deep dyspareunia, that means whenever a female is going for a vaginal penetration, when does she experience a penetration? When does she experience a pain? So is she experiencing pain at the time of penetration? So it is very important when you are assessing a female, and particularly you are taking the history of a female, at that point of time, you might have to ask her the questions about when does she experience pain? Does she experience pain during penetration, or she experience pain during deep sexual activity? So there can be two possibilities. First is, ma'am, whenever I'm going for a sexual activity, or whenever I have to penetrate, like 38-year-old female came up with a complaint of dyspareunia, experiencing since last 6 months, and she came up for the examination. And when we did the examination for her, she always used to say that whenever I'm going to penetrate, the penetration is always painful. It's very much painful, but once the penetration happens, after that I don't have pain. So I tell my husband that you penetrate once, you finish the activity and come out. Don't insert and come out again and again. So that is a pain at penetration, during penetration. Okay, so that is a superficial dyspareunia. That is superficial dyspareunia, means your superficial muscles are involved, or maybe you have lack of lubrication, or maybe you have a scar tissue, or maybe there is a perineal tear which has happened, or your skin is so dry that it is tearing. Yes, the way we have cracks on our lips, we can have cracks over the vaginal area if the vagina is too dry. Okay. Postmenopausal female who have estrogen deficiency, vaginal dryness. So they can come complaining that when the penis penetrates, I feel like it is hitting something and it gives me pain. And so, and then I am just tightening myself. And then once it is, then the pain is not there. That is a superficial dyspareunia. Okay. And second is a deep dyspareunia. So deep means, ma'am, penetration is all okay. I don't have a problem in penetration, but once inside and once there is a deeper thirsting activity, I get pain. I get pain. So that is a deep dyspareunia. The deep dyspareunia. So once the penis is inside, the thirsting movement is giving pain. So that is a deep dyspareunia. What does that specify? The deep dyspareunia can specify spasm of the inner layer of pelvic floor, the levator ani. It can even specify underlying pathologies like endometriosis, or it can even specify the cervical pathologies. If there is recurrent cervicitis, or if there is cervical inflammation, or if there is maybe even a inflammation of the deep layer of the pelvic floor or endometriosis, that can lead to a deep dyspareunia. So in a superficial dyspareunia, you will have pain during penetration. In deep dyspareunia, you will have pain during the thirsting movement. Penetration is not painful, thirsting movement is painful. That is a deep dyspareunia. Now, the next thing is, the most important thing comes, that is this. The vicious cycle of pain and spasm, which every hypertonus or vaginismus dyspareunia female undergoes. So what does this vicious cycle states of? So it goes like, too tight pelvic floor muscles create pain during penetration as they fail to relax. Okay, if the muscles are too tight, they are not relaxing, they will lead to pain. Okay. Now, once you attempted, there is pain. Okay, you left it. Again, you tried, there is pain. You left it. Again, you tried, there is pain. You left it. Now, what will happen? Third time or fourth time, before the activity, she will have pain. Okay, that is an apprehensive behavior, anticipation. In anticipation of pain, the muscles will go into spasm. Okay. So when it happens repeatedly, patient starts anticipating pain even before the penetration. Okay. As a result, emotional anxiety of anticipation of pain can cause more spasm or tightness of pelvic floor muscles. Okay. And similar spasmodic or over tight pelvic floor muscles can lead to more anxiety and more pain. So you're entering the cycle of pain, spasm, spasm, pain, pain, spasm, spasm, pain. So there is a vicious cycle. Now, this is the point which we need to intellectually understand, that when you are treating a case with a vaginismus dyspareunia, you are not just treating the muscle, you are treating the mind. You have to counsel the brain that it is just a muscle which is in spasm. We will do a rehab, your spasm will reduce, you will feel better, and you will have a penetration. Okay, so you have to work at two levels. You have to work at on the muscles, as well as you have to work upon the brain or the mind perception. Okay, so in hypertonus cases, it is very important, it is very essential that we have a good communication, and we do a lot of counseling even during the rehab session. Okay, so that is, and that has been reflected by this vicious cycle. Always remember this vicious cycle. It does not just apply to the partner, it also applies to you. Patient of vaginismus came who has a fear of penetration, and we said that okay, we have to do a treatment where I have to palpate your muscles, and okay, the thought itself will give her spasm. So you don't start with penetration. Okay, you might start first with relaxing her, with counseling her, while applying the treatment over the external mons, the external perineum before penetrating. Okay, so how to decide what to do? I will be like, what should we do the assessment? So the assessment, we should always follow the SOAP, SOA and P, subjective, objective, assessment, and plan. So first take the subjective history or the subjective assessment, and the more detailed you can be, the better it will be. Okay, so and be a listening ear. Sir, he always say that every pelvic floor patient is different. Every patient itself is a book. So you just should have ears to listen to the patient, and half of your assessment would be done in that. Okay, so make sure to take a detailed assessment about the history, the chief complaint, the name, and if it is a secondary vaginismus. Okay, after the childbirth, then also ask for details of any other associated problems or pathologies. You might be surprised that why have I written urine leakage here? But even a case, a female with urine leakage can have vaginismus. That will fall under incoordinated dysfunction. Okay, so even that can be possible, that vaginal muscles are into spasm, but urethral muscles are weak, and that's leading to leakage with vaginismus. Okay, don't worry about those terminologies. This is just a webinar to give you an open and insight about the pelvic floor and vaginismus. It is way more beautiful than what it seems on the webinar, and there are a lot many histories to be taken, but the common things which you can start right away. First is the subjective history. Second is the objective history. Observe the perineum, observe the gait, observe the posture. The way she is walking in the room, is she too much hesitant? Is she taking small steps because of the pain in the perineal area, or she is comfortable? Okay, the way she sits, her sitting posture, her gait, observe that, and then observe her perineal area, then observe her perineum. So when we have to observe the perineum, try to observe everything in the perineum. Okay, how are the labial structures? How is the majora? How is the minora? How is the vagina? So can you see it as relaxed like this, or it is like this tightened? Okay, can you differentiate? Okay, so either you have this type of a tone, or this is the tone. If this is the tone, it is tight pelvic floor. This is maybe a less tight compared to this. Okay, so observe the perineal area. Okay, and then there are certain gradings which you can do. So the gradings which we can do for the examination, there are one grading which are the lemon grade. So the lemon grade shows the readiness for the examination, whether the patient who is coming to your clinic, is she mentally ready for the examination? Okay, so that is a readiness questionnaire or a readiness grade. I will read it for you so you'll be able to understand it better. Grade 1 is patient is able to relax for pelvic examination. Okay. Grade 2 means patient is unable to relax for pelvic examination. So grade 1 is the patient, she is able to relax for the pelvic examination. Fine. Means She is ready. She came to your clinic. You took her history. You told her, I want to examine you. She is mentally ready. She said, yes, let us examine. That is grade 1. Okay, grade 2. She came to your clinic. You explained her. You told her, I want to examine you. She said, no, I don't want you to examine me. Okay, or she's on the couch and she is giving you some body signals which shows that she is not relaxed for the examination. She's tightening her glutes, she's adducting her legs, and she's not ready. That is layman's grade 2. Grade 3 means buttock lift and early retreat. So before you reach her perineum, before you reach her waist, she is trying to move aside, or she's just grabbing her. So that is a buttock lift off the table and early retreat. Grade 4 is generalized retreat. The thighs are too much closed. She's completely tightened up and she is not able to relax herself. That is grade 4. And grade 5 means a very much extreme where she hyperventilates, she gets a panic attack, and she gets into hysteria, or she just run away. This is a grade 5. So the Layman grade, it shows you the readiness for the examination. It does not show you the level of involvement of pelvic floor. Okay, so this is a grade to just check whether she is ready or not. That's it. It's simple. Okay, in the this binary language, yes or no. That is this grade. Okay, so if you want to check the readiness of the patient, whether she is ready for the examination or she is not ready, you can take the Layman's grade. But when you have to, as I said, that it will not help you to identify the pelvic floor involvement. Okay, so when you want to examine the involvement of pelvic floor muscles, we can take the Haig's MMT. Okay, why not modified Oxford MMT? Because modified Oxford MMT does not give you a grade for relaxation. Modified Oxford MMT only gives you a grade for contraction. And when we are talking about vaginismus, when we are talking about dyspareunia, it's very important to have the grades for pelvic floor relaxation. Okay, so Haig's MMT, which is being designed and developed by Haig sir, with a view to make sure that no one suffers through pelvic floor dysfunction, and a pelvic floor examination can be included as a routine checkup with a perspective of prevention. Sir developed the grade, which is beyond the boundaries of modified Oxford MMT. So when we talk about, I wish all of you please, if you want, we will be sharing this grades with you. We will be sharing the sexual function scales with you. You can just get back to Learnovate, and I'm sure Dr. Suma and Dr. Faik would be very happy sharing all the materials with you. So I request, please don't write on the screen. Thank you. So you can, those who want the grades or those who want the scale, they can just get back to Learnovate people, and we will be very much happy to provide you with this, so that it can ease your examination. That is secondary. But if as a female and even as a male, you should be guiding your mother, your sister, your daughter, maybe your wife, to do an examination of pelvic floor muscle every month. Okay, because pelvic floor dysfunctions are more common than we assume them to be. Out of 10, 8 mothers are sufferers. Okay, so if I am a mother, I can also have a chance of suffering. If you are a mother, or your sister who is a mother, or your friend who is a mother, she can also be a sufferer. Okay, so technically speaking, every person sitting next to you can have a pelvic floor dysfunction. It's more spreaded than back pain. Only thing is, it is under the rug. It is like a tip of an iceberg. We don't want to talk about it. Shoo, no, that's it. But not anymore. So the least or the bare minimum what we can do is, at least we can educate ki, acha, you do not want to get treated by someone else, or you do not want to get assessed by someone else. Assess your own self first. Check whether you have a good pelvic floor muscles or you don't have. Okay, so the grades are very simple. Grade 0 is the baseline tone. So that is the normal resting tone we all are right now. So we are 101 people right now. So 101 is the register, the number which is seen to me. So all of us, we are either eating or drinking water, playing with our kids, listening to the webinar, me and speaking, someone would be driving, but definitely we are not using our pelvic floor right now. Okay, means we are not voluntarily using it for urination, defecation, or the activities. It is at a baseline tone. It's normal resting tone. 0 is the baseline tone, the normal resting tone. Okay. From the baseline tone, if a female comes and you do her examination, or she is self-examining herself, when she tries to penetrate and you are unable to penetrate, you could not penetrate inside, or she could not penetrate inside because of pain, because of fear, because of tightness, because of spasm, that is inability to penetrate. So -1 is inability to penetrate. Okay. -2 is a symptomatic penetration. -2 is a symptomatic penetration. When there is penetration is possible, but with symptoms of pain, tightness, discomfort, or any other symptom. That is -2. -3 means asymptomatic penetration, a very easy penetration. So -1, inability to penetrate. -2, symptomatic penetration. And -3, asymptomatic penetration or easy penetration. Okay. Right. So it is a very simple yet highly efficient scale to examine your pelvic floor muscle relaxation. So repeating once again, 0 being the baseline tone, -1 means inability to penetrate, -2 means symptomatic penetration, and -3 means asymptomatic penetration. Okay. 1. Now, once you are inside, so these are the grades. These are the relaxation grades, which helps you to understand how much is the relaxation of pelvic floor muscles, how much pelvic floor are relaxed. Whether they are -1, that is inability to penetrate, they are -2, that is symptomatic penetration, or -3, that is asymptomatic penetration. Ideally, our pelvic floor should be -3, asymptomatic penetration. So if you're giving a command to your patient to relax, she is able to relax, and there is absolutely no pain anywhere inside. That is a completely relaxed pelvic floor. Okay. Next is the grades for contraction. Grade 1 is mild contraction from either side. So once you are inside and you are getting a mild contraction from either side, that is grade 1. A grip with complete circumference is a grade 2. And a strong upwards and inwards pull against resistance is a grade 3. Okay. So grade 1 is a mild contraction from either side. You are inside and you give a command to the patient, squeeze as if you're trying to hold the urine. And you can just feel a flicker contraction, that is grade 1. Or you feel a strong, or you feel a grip with complete circumference. You can feel a grip throughout your finger, that is grade 2. Or you feel a strong upwards and inwards pull against resistance, that is grade 3. So grade 1, grade 2, or grade 3. So these are the grades for the contraction, or for assessing the strength of the pelvic floor muscle, its contractility. So basically, your pelvic floor muscles should be at a grade of -3, that is complete relaxation, and +3, that is strongest contraction. So the grade should be 3 or -3, complete relaxation or the strongest contraction. Now, there are another scales which are used to check the sexual behavior of a female, because vaginismus and dyspareunia, these are the sexual dysfunctions. So we need to check the grades which are like their sexual behavior as well. What is their libido? What is their arousal? What is their orgasm? What is the lubrication? So all this, and how much is the pain? So all these components needs to be assessed individually to find out the involvement of pelvic floor muscles. Okay, so there is an FSFI scale through IUGA, that is International Urogynecological Association, but it is a 19 questionnaire scale, and every questionnaire has its own score number to multiply. So it is a very much cumbersome, like the statistical analysis of the scale is quite cumbersome. You have to multiply it with its own component, and then you have to add it, and then you are getting a final outcome. Plus, it is not been designed keeping the pelvic floor in mind. So it is a purely scale designed for the urologist and the gynecologist. Okay. So it is not dividing a hypertonous pelvic floor from a hypertonous pelvic floor. And this limitation is being taken care by Desai sir through FSFI, that is Head's female function scale, which has the component of laxity as well as pain. So you can have the individual scales for hypotonus as well as hypertonus dysfunction. Again, if you want, we can share these scales with you. So the minimum score is 0 and the maximum score is 10. You can measure from 0 to 10. And 0 to 25 shows a poor sexual health. 25 to 40 shows an average sexual health. 40 to 50 shows a good sexual health. Okay. So that this scales, all scales we can share with you. And then comes, like we discussed about the vaginismus, the dyspareunia. But the next thing comes would be rehab, what to do in case of vaginismus and dyspareunia. So it is basically two letters or two alphabets. Hey, sir, he always say that whenever you get a hypertonus case, a case with a tight pelvic floor, just remember two pathology, just remember two letters, R and P. R and P. What and RP and PR. What is RP and PR? So first is reduce pain. The patient is in pain. Your primary duty is to reduce pain. And second is to promote relaxation. Okay. So you reduce the pain and promote the relaxation. That is the key to the pelvic floor rehab of vaginismus. Okay. So we can divide like reduce pain, promote relaxation, soft tissue mobilization, and then comes the functional training. So first is to reduce the pain. Now, in order to reduce the pain, there are various modalities which are available, like IFT, like ultrasound, like heat therapy, like cryotherapy. So you can use either of these modalities, IFT, ultrasound, cryotherapy, heat therapy, like this. Okay. For example, if you want to use the IFT is interferential current therapy. Instead of IFT, can you use TENS? Yes, you can. It is relieving the pain. Your ultimate goal is to reduce the pain. Can you use dry needling? If you are an expert in dry needling, you can use it. Only if you are certified to do it. Okay, only if you know how to perform it. Don't experiment dry needling on pelvic floor. It is not at all my recommendation or our recommendation to do it the first. That should be your last and the final option. That too, if you are trained, certified, practiced, and confident enough. Not the first one. Can you do dry needling for piriformis? Yes, you can. If you feel the piriformis is tight and that is reflecting to the pelvic floor, you can do it. Okay. So whatever you can do to reduce the pain of the patient, you should do it. Okay. So simple example is IFT. So yes, you can use IFT. How can you use it? So this is symphysis pubis. This is ASIS. So you can cross the channels like this. Channel 1, so medial 1/3 and posteriorly. So you can cross your channels like this, 1 and 2. And the treatment area would be the perineum. And you can set maybe just a minute. You can set an area, or you can set the parameter like you can, okay, there is a question in the chat box. Let me just finish this and I will get back to the question. Okay. So you can use a pain relieving parameter 90 to 110 where your pain gets relieved. Okay. Or if you are using an ultrasound, you can use an ultrasound using a water bag method. So you can keep a water bag filled, like a glove filled with water, keep it upon the perineal area and use the ultrasound over it. You can simply use a water bag method ultrasound. Okay, use 1 megahertz because you need a deeper penetration. Use for 5 to 6 minutes, and use continuous because you already have the water bag. So if you are keeping pulse, the attrition would be higher, the attenuation would be higher. So maybe you can use the continuous, and depending upon the chronicity, if it is acute, you can use an intensity of 0.5 to 0.7 watts per centimeter square. If it is subacute, 0.7 to 0.9. If it is chronic, maybe 0.9 to 1 watts per centimeter square. You can use, so your goal is to reduce the pain. Okay, your goal is to reduce the pain. So try to use the modalities, try to use the relaxation techniques which can help you reduce the pain. Okay, once you can even use cryotherapy. How can you use cryotherapy? You can use a glove which is filled with water, place it upon the perineal area, the cold water, okay, or a condom filled with cold water, place it over the perineal area. Cryotherapy can be done by the patient herself. Okay, let her do the cryotherapy by herself. Okay, so that's how you can use the cryotherapy. Or you can use the sitz bath. Depending upon your clinical judgment, you can use the sitz bath to help her to reduce the pain in the perineal area, to supple the area, to soften the area. Okay. Next would be relaxation, relaxing your pelvic floor muscles. So what can you do to relax your pelvic floor muscles? Okay, you can use various visual imagery techniques. Okay, you can use various visual imagery techniques. The first can be a mirror itself. So you can keep a mirror in front of the perineum, show her the perineum, tell, see, this is your perineum, which is tight. Relax, let it go. Relax, relax, relax. Relax to the deepest possible. Then don't just give command to relax. You can literally ask her to close her eyes, sit back, relax. Okay, we all can do it. Please, all of you, just sit back, relax yourself, relax yourself. Okay, and simply focus upon your vaginal area. I know all of you might not be hypertonous. Just simply focus upon. I can see that we are quite ahead. Like we are past 9. But please be with me. You will definitely enjoy it post session. So please be with me, and just focus the male, please focus upon your anal area. The female, please focus upon your vaginal area. Close your eyes, sit back, relax, and just listen to my commands. Okay, just listen to my commands. See your vagina. Okay, you have tightened it up. Just relax and open your vagina. Assume your vagina to be like a flower, and relax and let it open. Let it open, let it open. Relax, let the flower bloom. Relax, relax, relax. Yes, very good. Relax it, open it, open it, open it. Let it go. Don't hold on. Let your legs be relaxed. Relax your legs. They are so tired, holding you up for the whole day. Let them go. Let them go. Relax. Relax. Very good. Relax your legs. Relax. Focus back upon your anus and vagina. Let it open. Let it open. See, it is like a flower. The muscles are tight. The muscles are all sore. Let them go, let them go, let them go, and relax. Let them go and relax. Let them go and relax. Very good, very good. Relax, relax. Very good. Let them go. Relax. Very good. See, it is like a lift and elevator. A lot of people inside. Open and let your vagina be relaxed. Be relaxed. Good. Great. Relax. Let your anus be open. Relax, relax, relax. Very good. Very good. Very good. Now, slowly try to squeeze. Squeeze, squeeze. Okay. You are on in an elevator. You reach the basement. Slowly squeeze and come to the ground floor. Squeeze, gently squeeze and come to the ground floor. Bus. Relax, be there. Relax, relax, relax. Let's go back to the -3, the basement. Relax, relax, relax. Open, relax, relax. Very good. Let the flower open. Leave all the tension. Leave all the tension. Open the door. Yes, open the door. Very good. Very good. Could you do it? Could you do it? Could you follow my command? Any one of you? Okay. Okay. I'm not getting any answers. I hope you could. But see, when we talk about
Yes, ma'am.
okay, thank you. So when we talk about the tightness or when we talk about the hypotonus, our commands would be squeeze, try to pull your muscles in, try to suck the water in, try to suck the
Ma'am,
yes,
one
yes.
more doubt, ma'am. Ma'am, are you now you told me one comments, right? Is this same like Kegel exercises?
Yeah,
No, right?
these are the reverse Kegels, dear.
Ah, that's why. Okay, fine. Normally hearing only about the squeezing and tightening of the vaginal muscle. Now you are telling to open it like that. Towards
Yes.
the basement means we have to make our buttocks towards the ground or the bed like that.
No. It is not. You don't have to press your buttocks towards the ground. You have
Okay.
to see if this is you imagine this your vaginal opening.
Yes.
Okay? You have to imagine. Okay, this is at the ground
And
level.
ground level.
Okay?
Oh, yes.
Now you just have to simply relax and open it. Relax and
Okay.
open your vagina and
Okay.
reach to the basement.
Mm.
Like that, or it is a flower, you are just relaxing and opening your flower. So when we practically do it, we can even use some dilators, or we can even use some feedback, a pelvic floor feedback devices, which we
Okay.
insert in the vagina, and then we ask the patient to relax and let the device fall out.
Okay,
That
fine.
is opening up. In hypotonus, we focus upon tightening, squeeze and tighten. In hypertonus, we talk about
Yes.
relax and
Okay,
open.
okay. Thank you so much, ma'am.
Thank you, dear. Could you understand it?
Yes, of course, I understand. I'm normally hearing about this, only focusing about hypotonicity, not hypertonicity. Okay, fine.
Yeah.
Ma'am, is it we can include with this pelvic tilting exercise also?
Yes, you can include pelvic tilt, you can include gentle pelvic rotations, you can do all their variations, but not at the first. First goal
Okay.
would be to make them understand relaxation
Understand,
at the
yes.
base. Yes. So first they
Okay.
need to understand what is relaxation. Then they have to practice relaxation in all possible movement. So when you are walking, try to relax and walk. Hypertonus case, they will
Yes.
have a tendency to tighten their muscles. So
Okay.
they are the skeletal muscles. If you are suffering through chronic neck pain, you will be habituated to tighten your trapezius.
Of course.
Right?
Yes.
Even if you have to use your fingers, you will you might recruit your trapezius first.
Yes.
Same applies for pelvic floor. When the pelvic floor are into spasm, when they are tight, you need to relax. You need to let them go open and understand the relaxation. That's the key.
Okay, thank you so much, ma'am.
Most welcome, dear. Understood. So this is like you can give different, visual. You can give different commands that open the umbrella, or open the flower, open the elevator door, open the door of your house, open the window. So there can be multiple visual images, or you just try to relax and set back, but there can be multiple cues of relaxation, or you can even have a smooth or a soft music getting played at the instrumental, not a very loud music but a soft instrumental music in the background, and you can give the commands. So the better she will be relaxed, the better she will be ready for the next session. So after the relaxations, you can even do soft tissue mobilization. So the way we mobilize our trapezius, the way we mobilize the deltoid, the way we mobilize, the biceps, the way we mobilize the brachioradialis, we should mobilize, we can even release or mobilize the trigger points or the tender points which are developed inside the vagina. Okay, yeah, it might sound scary, but it's true. Okay, many females, they have tender points or trigger points inside the vagina. Okay, they are inside the vagina. So you can simply use techniques like sweet spot release. I will not be able to cover all the techniques, but certain, yeah, along with before, like you can go for stretches, all the lower limb tight muscle stretches like hip flexors, piriformis, adductors, and all. And yes, we can go for soft tissue mobilization techniques like paradoxical relaxation, Thiel's technique, sweet spot release, ischemic compression. So let me explain few of them. One is like the ischemic compression. So ischemic compression is the way we do it for the external muscles, that you palpate the area which is painful. Okay, hold it for 40 seconds and release. Again, palpate the area which is painful, hold it for 40 seconds and release. That can be ischial compression. Similar can be sweet spot. So in sweet spot, in ischial compression, you are pressing the area. In sweet spot, you are not pressing the area. In sweet spot, you are gently keeping your finger just over the area. Okay, just like this. Okay, and you give her a command, okay, relax, relax, relax. It is just a touch. It is not a pressure. It is just simply a touch. And then let her relax, 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 relax. And slowly you can increase your pressure. Okay. So that is a sweet spot release. Or you can use a Thiel's technique. Thiel's technique is simply a scooping massage inside the vagina. So you feel there is a tight band. You just release that tight band with the scoops. Okay. So these are the techniques, or you can release. You can even give just a stretch, just an external stretch like this. Okay. So these are the relaxation techniques. These are the opening activities which you should do. And yes, one very important thing, if you are doing manual therapy, if you are doing releases, then post-release, there are chances that the muscle will go into flare, right? So in order to prevent that flare, you can go for cryotherapy. So the cryotherapy, you can include maybe after the manual release, okay? So that can be the soft tissue mobilization. This is how we are doing the sweet spot release, that you just have to palpate the area, palpate the area which is painful and just hold that. This is how we conduct our hands-on workshops. So, and this is how we teach the patients, the practitioners, to do the sweet spot release upon each other. This was our, yes, the last session where we even did a transrectal release. So this was our Dubai ka session, which we had with Learnovate 5th and 6th of November 2022. We are again coming on 18th and 19th of March 2023. It was a very wonderful session, and we are teaching them to do a transrectal coccygeal mobilization, how to mobilize the coccyx, how to release the muscles when they are into spasm. So that is the session which was going on. Yeah, so this is how our workshops and webinars are generally, where it would not be just verbal. You will be able to release, you will be able to learn how to release, you will be able to practice how to apply all these techniques upon your own. Yeah, and one thing which the vaginal dilators. So I don't know how many of you have seen the dilators, but these are the dilators. I would like to quickly show you the dilators also. as well as the, so these are the dilators. Okay, so these are the sets of dilators which you can use to, one after another. So you can maybe start with the smallest diameter dilator, and then you can progress to the larger ones slowly. So you can start with the narrowest dilator and then just relax once she's comfortable with the narrowest one. She's able to relax with the narrowest one. Then maybe you can start with the second dilator. So these are the sets of the dilator. This is the holder. So we can use even a dilator for the hypertonus cases, as well as we can even use the EMG. Have you heard about EMG? We can use the EMG to release or to relax the pelvic floor muscles. So the biofeedback, the best biofeedback would be the mirror biofeedback, very cost efficient. Okay, no cost is involved, very cost efficient. Second can be the dilators or even the biofeedback. So you can keep the electrodes on your perineal area. You can see them, that see your muscle activation is too high, relax and come down. Take a deep breath in, relax and slowly come down. So you can give them commands and you can teach them relaxation. So that is all what we can do into this is a gist of what we can do into the vaginismus and dyspareunia. The purpose of the webinar was to make you understand that Kegels or contraction is not the thing. It's not the name of the game. Pelvic floor is like ocean. It is very beautiful. If you will jump into it, there are lots, and it's like an onion peel. You peel one, you peel the, remove the first layer of onion, there will be second layer. Remove second, there will be third. Remove third, there will be fourth. And in between, you will have a beautiful bulb. That will be the bulb of satisfaction. So pelvic floor rehab is a very much detailed work, and Kegels or contractions is not the only thing. It is way more than that. There are relaxation techniques, there are stretching techniques, there are mobilizations of the coccyx, there are releases of the obturator internus muscles, and a lot. There are home exercise plan and all. So we would be covering all these things into our next course, which is on it will be a hybrid course, online and an offline module. So the online module is of 7 days, 9th to 16th of March, and 18th and 19th of March, we will have 2 days hands-on workshop. We would be conducting it in Dubai. Last time also we were in Dubai, now also we are in Dubai. So we will be there in Dubai on 18th and 19th. Sorry, we earlier was in Abu Dhabi. It was in Abu Dhabi, but now we have shifted to Dubai because we had a lot of requests from the Dubai candidates to conduct it in Dubai. Okay, and there will be a detailed of everything: interstitial cystitis, endometriosis, sexual dysfunctions, constipation, inflammatory bowel disease, pelvic dyssynergia. All these things would be will be discussed in detail into 7 days online and 2 days offline hands-on workshop. And yes, that's not it. The best part of the webinar, I think, is now that this thing, like this whole pelvic floor workshop which we are offering, it is inclusive of 7 days level 1, 2.5 hours each day, 14 days of extensive online training, followed by 2 days of hands-on workshop on 18th and 19th. And be prepared, the hands-on workshops will be completely practicals. There will be very minimal theory and majority would be practicals. And you are going to love that. I'm sure about it. And along with that, those who are joining us for level 1 and level 2, you will also get the online module link, which will be available for 3 months on female sex health rehab as well as reproductive health rehab. So in just one package, you are going to get level 1, level 2, reproductive health webinar, female sex health webinar, plus the candidates who have attended our today's workshop webinar on vaginismus, if you are registering within 48 hours, you are having one more attraction, or you are having one more benefit, that is 250 AED off on your registration. All you have to do is you have to apply this as the coupon code. So you can apply PEL 250 as the coupon code, and you can, if you are registering within 48 hours, you will be getting 250 AED off. Okay, so it's a very simple way to register. This is the link. I will be pasting this link into the into our chat box as well. You can, simply press this link. When you will press this link, you will go to the website of the Learnovate. In the website of the Learnovate, can you see my screen, all of you?
Yes, it's visible. It's clear.
It's clear.
Yeah.
So you can just go for buy now. When you would do buy now, you can enter the email ID. I would enter mine. And
The website is not showing, but your presentation is visible. That's all right. I think it comes down. I think people have registered. They've seen
Okay.
it. Yes,
So
I
when
think
you,
that.
right. So when you will enter your email ID and when you will enter your ID password, you will be upon the page where there will be the payment, and beneath the payment summary, you will have the coupon code. So you apply the coupon code PEL 250 and place the order, and you will see that there will be 250 AED reduced from the price it is showing. So it's going to be a very win-win situation for all of you. I'll be keeping this link into the website, into our chat box, so you can easily get it. Just a minute. Yes, if you register within 48 hours, you will be able to avail this services, this discount. Okay, let me share the link here. Just a minute. Yeah, so I copied, and yes, to everyone. Yeah, so this is the link. You can press and you can, avail the services of Learnovate. Thank you, Learnovate, for giving such a wonderful offer. And a short explanation on who we are. So we are, as I said, these are our licensed clinical instructor, and this course would be female to female only. There would not be any male participant entertained. So it will be exclusively from a female instructor to the female attendees. And I'm very much grateful and I'm very much thankful to Dr. Desai sir, because sir is our chairman and founder of WOW IP, that is International Institute of Pelvic Floor Research, Rehab and Education. And this was his vision. He has envisioned that pelvic floor dysfunction should not be a taboo anymore, should not be a suffering anymore, and let us take all the minimal possible steps to irradiate it. So I'm so much grateful and thankful for Hed sir for giving me an opportunity to be the part of his larger than life vision. I always say it is larger than life, because we will go, but the pelvic floor will not. And if we will treat our patients, maybe they can have a better life and they will be able to, help upcoming generations for future. So it's not about today, it is larger than our life. That's why I always say it is a larger than life vision. So thank you, sir, for making me a part of the team. And we are the only government recognized institute from India to receive the certificate of recognition exclusively rehabilitation with a legitimate DIPP number. And we are the global leaders training in 13 different countries. Source book, that is Hate's Manual of Pelvic Floor Rehabilitation, He has written a book on Haig's Manual of Pelvic Floor Rehabilitation, which by the grace of God is Amazon's bestseller in urology. Amazon's bestseller #1 in urology, Amazon's bestseller in obstetrics and gynecology and physical therapy. And it is also a recommended textbook in the Master of Physiotherapy Women's Health in Gujarat University. Sir has multiple academic contributions, intellectual properties like Haig's MMT, which is being introduced in State University of Gujarat in MPT, Masters of Physiotherapy, as well as we have publications on Haig's MMT in ICS, Australia, Melbourne 2021. Haig's FMT. So Haig's FMT is it is a tool which is designed to objectively measure the pelvic floor muscle laxity. So it is first of its kind patented tool designed by Haig Desai Sir. Haig's string clock assessment, SOF assessment, Haig's providers protection guidelines, reflexive result scale, female sexual function scale, and male sexual function scale. There are multiple endorsements from the national and international dignitaries as well. And Sir has multiple innovations in the field of pelvic floor. And yeah, thanks and big salute. Thank you very much for being with us. And there are a few questions, if I can just quickly take them. Yeah. Yes. So, Dr. One is asking for the grades of contraction and relaxation. Okay, and the Lemon's grade. Let me explain them. And one query: pelvic floor can be used, can be done using ultrasound. Yes, diagnostic ultrasound can be used to check the pelvic floor muscle relaxation as well as contraction, Dr. Anuja. So you can use a diagnostic ultrasound to check the pelvic floor behavior. Yes, you can use it. And
What frequency we can use, Dr. Dhara, for that? Means I am not sure because one of my colleague used it, but I mean, before where I was working for ultrasound to check the contraction, it's like a biofeedback. She had used it.
yeah, so you can use that would be a diagnostic ultrasound, and there you don't have to set the frequency parameter. You have to set the parameter like depending upon the instrument you are using. You need to set the parameter like whether you want it a gynec. Again, every ultrasound will have its different settings. But many of them, they would divide whether you want an abdominal view, you want an gynecological view, you want a musculoskeletal view. So we will be setting it like a gynecological view where you can observe the bladder. So we basically have to observe the bladder. I have a video. If if I can show you, I will be showing you how can you see the lift. Just give me a couple of minutes. I'll just go through other questions and I'll get that. Yeah. Okay, so one is I have to show the Lemons grading. I will be showing the Lemons grading. Another question is, do we have to use the lubricants for soft tissue mobilization? Yes, we have to use the lubricants for soft tissue mobilization. There is one more question that mostly we see hypotonic cases where we strengthen the pelvic floor. How often do we see the hypotonic cases? What are the causes behind it? So, Dr. Mumtaz, the hypertonic cases are also prevalent. The only thing is people are not able to understand that they are hypotonous. Many of the times the hypertonus is being misdiagnosed and as hypotonus is being treated with Kegels and the condition has been worsened. So the causes behind the hypertonus can be, as I said, vaginismus, dyspareunia, endometriosis, interstitial cystitis, pelvic inflammatory diseases, inflammatory bowel diseases, chronic stress and anxiety, urethral constrictions. So there can be any organic or any visceral pathology which is leading to spasm of the pelvic floor can lead to a hypertonic pelvic floor. It can even be a pudendal neuralgia as well. So there can be multiple causes for hypertonic pelvic floor. Okay. So, okay, then I think then there are no other questions. So there are two questions. One is the layman grading and okay. And then the ultrasound. Okay. Normally this question I asked. Yeah. Any other questions? Oh, I hope that you enjoyed the session. I myself enjoyed a lot, as always. So I hope those who joined with us also enjoyed it. Yeah. So, see, Lemon's grading, doctor, Lemon's grading are showing the readiness of the patient for the examination. So, whether the patient is ready to get an pelvic examination or not, that is Lemon's grade. So, grade 1 is patient is unable to relax for pelvic examination. Grade 2 is patient is unable to, sorry, grade 1 is she is able to relax. She is on the couch. You tell her, okay, relax, let me examine. She is allowing you to examine. So, she is relaxed. Grade 2, she is unable to relax. She is not relaxed. You can make out from her face, she is not ready for the examination. She is not relaxed. Grade 3 is buttock lifts off the table and early retreat. So she is like literally pulling herself away from for the examination. Grade 4 is a generalized retreat, buttock lift and thigh closure. So completely closed movement. Don't examine me. That is the that is the behavior. That is a generalized retreat. Grade 5 is a generalized retreat as in level 4 plus visceral reaction, which may result in any one or more of the following. So she can have palpitation, she can have hyperventilation, she can have sweating, she can have severe trembling, uncontrollable shaking, screaming, hysteria, wanting to jump off the table. So there can be serious consequences. That is the grade of the readiness. And the another are the Haig's MMT, which is to check the pelvic floor muscle involvement. So 0 is the baseline tone, okay, the normal resting tone. -1 is inability to penetrate. You cannot allow the female to have a penetrate. The female is not allowing you to penetrate inside. That is -1, inability to penetrate. -2 is symptomatic penetration. The penetration is possible, but it is with symptoms. That is symptomatic penetration. And -3 is a completely asymptomatic penetration. A complete relaxation is -3. Once inside, when you ask her to squeeze, you can feel a mild contraction, that is 1. A grip with complete circumference is 2. And a strong upwards inwards pull against resistance is grade 3. Clear, doctor? Yeah. So if you want, we can share this gradings also with you. And Dr. Anuja, just a minute. I will show you how the this lift you can see. I have a very short video though, but I hope it will clear your doubt. For this thing. Just 1 second. Do we have any other questions? So 1 minute, Dr. Anuja. Yeah. Can you see my screen? Yeah, can all of you see my screen? So I'm just playing this. See, this is the bladder. This is the bladder, and here is the pelvic floor. So when the pelvic floor will contract, you will be able to see the lift of the bladder upwards. Dr. Anuja, are you here? Yeah. So this is how the lift of the bladder you can view with the ultrasound. And then you will be getting like all the diameters, like how much the lift is. You can, the way we measure, you can measure is like how much is the lift, how much is the relaxation, like that. Okay.
Thank you.
Okay, there are a few questions that are these exercises contraindicated in pregnancy? And during pregnancy, the re-education is allowed between 4th and 8th month. 4th and 8th month. See, pregnancy and pelvic floor is a completely different thing. There are lots of things which we need to keep in mind when we are designing a rehab during pregnancy. Depending upon her need, we will be designing the exercises. So in pregnancy, depending upon whether it is low risk, moderate risk, or high risk, the exercises would change, the pelvic floor rehab would change. But one thing which would be constant will be that initially you need to strengthen your pelvic floor muscles. You need to work upon the strength training of your pelvic floor muscles. And after 36th week, like once the relaxing again peaks, you have to relax your pelvic floor muscles. You need to do perineal massage. You need to do relaxation. You need to do pelvic widening exercises. You need to do duck walking. You need to squat, and so that the vaginal opening becomes enlarged and you can have an easy and comfortable delivery. But before initial weeks, you should focus upon the contraction or the strength training of the pelvic floor muscles as well, though not invasively, then at least non-invasively. Okay, so depending upon which trimester it is or what is the risk of pregnancy, the exercises sessions would change. Yeah. Okay. Strengthening of the pelvic floor muscles will have different phases. Whether you want to strengthen the pelvic floor muscle through its endurance, through the fast twitch activity. So depending upon the need of the patient, you need to check the endurance of the patient first. And according to the endurance of the patient, you will plan the rehab. So for example, if the endurance, like you feel that the muscles, you need to do both the things, that strength training as well as the quick contractions. So we might start with 1 second hold, 1 second relax, 1 second hold, 1 second relax, progress to 2 seconds hold, 2 seconds relax, progress till 10 seconds hold, 10 seconds relax. And along with that, you go for quick pelvic floor contractions. So fast twitch contractions or quick contractions are needed in order to activate your fast twitch muscle fibers, and sustained contractions are needed in order to increase your endurance. Again, for hypotonic cases, we go for a detailed ring clock examination, that is Heath's ring clock examination. Which clock is weak? How much is the weakness? According to that, we can even use the PNF techniques, that is proprioceptive neuromuscular techniques like initiation, irradiation, hold and relax, fast twitch exercises if we specify. So I'm getting the questions from mentors.gulf@gmail.com. Okay, so when we talk about the fast twitch activities, you can timed them. So within, you can say them. See, there are two difference: squeeze, relax. This is once like squeeze, sustained, and relax, sustained. And when we go for quick contractions, so quick contractions are squeeze, squeeze, squeeze. Okay, so go for fast contractions. In 10 seconds, you have to quickly squeeze and relax your pelvic floor muscles. Quick contractions. So that are used for the urge incontinent patients as well. Because in urge incontinent, we will be focusing upon the fast twitch activities because there is a reflex associated with the pelvic floor and bladder. So all these things. So the moral of the story is, even if it is in hypotonic, you have to make sure that you are strengthening the pelvic floor, both the components, the endurance as well as the fast contractions. You have to work upon the fast twitch and the slow twitch muscle fibers. Okay, there is one more question, last question. Where do you order the rehabilitation machine of biofeedback and electrical stimulation? I'm from France. I settled in Dubai, and I am used to order on perinealshop.com, but I don't know where I can find my Phoenix Nano. I'm a physiotherapist. So, doctor, I think like for the rehabilitation devices and all, there are multiple on-sites, but when you are in UAE, you need to check upon the customs because UAE is a bit strict for the customs. So maybe you can search upon Amazon.com, and you can get it ported when someone is coming by clearing all the custom possibilities and all. But there are multiple biofeedback tools which are available. Pelvic Educator is there. There is Aquaflex is there. Prometheus Group is there. So maybe you can order whichever you feel comfortable, or maybe you can get it from the person coming from the overseas. Yeah. Yes. Great. Okay. Yeah, I can repeat it. I said that Aquaflex is there, or Prometheus Group is there, or iSteam is there, or Pelvic Educator itself. The name is Pelvic Educator. Okay. Okay. So I hope you enjoyed the session. Thank you very much for joining me. Lots of love from India. Looking forward to meet you on 18th and 19th of March 2023, and hoping to have a wonderful session together. Over to you, Learnovate. Thank you, Dr. Sumaya and Dr. Faith, once again for organizing a wonderful event. Altogether 100 participants. I hope you all are very much happy and satisfied. Good night. Bye-bye.
Thank you very much, Dr. Dhara. As always, and I would love to, I take pride in saying this, that as always, every session that I attend of yours is very informative, and especially the hands-on session that we had last time was, I would say, it really fired the brain of every participant who was there, and everyone went home with a lot of new information and learned that, pelvic floor rehab is much more than Kegels. It's not just Kegels. So, of course, your profile needs no introduction. All those who are interested, please do reach out to us. Do not miss the chance to learn from Dr. Dhara. She's an amazing instructor and has, she teaches everything patiently. So you definitely will go back feeling that you've learned so much that you can apply the very next day. That's, I think, and there is continued support from Dr. Dhara even after the course, along with the free modules that they were generous enough to provide for Learnovate and its participants. I think even her personal support is something that counts and adds a lot of value to the education. So feel free to reach out to us. And again, thank you, Dr. Dhara, for your time.
Thank you very much for
and the
your
amazing
help.
session. Thank you so much. Thank you, everybody.
Bye.
Bye.